As our society moves further into the 21st century, we are witnessing a revolution in medical technology. But one area in which this technology can be potentially harmful is reproductive medicine. While in vitro fertilization and other assistive reproduction technologies do often bring about pregnancies, they also carry risks about which every couple seeking fertility assistance must be educated. Infertility is a frequently overlooked problem and one which really begins with certain attitudes within the medical community.
The general profession of obstetrics and gynecology or reproductive medicine don't even care what's wrong with women anymore. They do not look for the problems. They just put them into an IVF program, artificial reproductive technology program, and that's it.
In the United States, there sometimes is not a real push to identify the cause of the infertility. We treat a symptom. The symptom is not being able to have a baby, whether it's problems with conception or problems with keeping the pregnancy. There are a number of clinics that are jumping immediately to in vitro fertilization, IVF, as opposed to doing a thorough workup of why the mom is having issues with infertility.
One statistic that's really telling, I think, is there is a national statistical database that is put together by the government along with one of the ART organizations. And the incidence of endometriosis, which is one of the conditions that causes infertility, in the year 2007, which is just a couple years ago, was 4%. When we study the same basic patients, we find endometriosis in over 80%. Now, why is there the big difference? Well, because we're looking for it. And these women never get evaluated, they never get any testing to be able to determine whether they have these kinds of conditions, whether they're hormonal or things like endometriosis or other types of physical or anatomical problems.
If you make someone be pregnant without treating the reason for the infertility, this is a higher risk pregnancy. We know that the moms have more complications, we know that the babies have more complications.
We have now gone almost 2 generations of women, young women who have had childbearing problems or fertility problems, where the profession as a whole has gotten to the point where they don't care what's wrong with you. And there's just something wrong with that approach. It's not in the best interests of the patient, it's not in the best interests of what medicine does best.
Symptomatic of this attitude towards reproductive medicine is the lack of education couples receive on the risks involved with assisted reproduction. Many don't find out about the complications until confronted with them face to face.
Babies are born prematurely purely because they are conceived by assisted reproduction. We don't know why. Often it's blamed on the fact that there's multiples, and multiples definitely have a higher risk even when naturally conceived of being born prematurely. But you don't have to be a multiple to be born prematurely. Assisted reproduction embryos carry that higher risk.
A mom who requires assisted reproductive therapy, if she conceives with a singleton pregnancy, we don't understand whether it's the mother herself or the process that is required to become pregnant, that they have a higher risk of premature birth, premature leakage of fluid, small for date babies, and babies for a given gestational age are very tiny.
This is not about blame of anyone who has successfully used assisted reproduction, and it's not to say that the children are not magnificent, but there's another side of the story that our current media often misses, and that's the folks who get hurt.
Infertility is a growing problem, one that affects 2.1 million women in America today. Over 7% of married women are unable to conceive a child naturally, owing to their infertility any number of factors, covering a wide range of internal and environmental variables.
The infertility is a couple that after 1 year can't conceive. And we find out that this is a relatively common problem. And around 10% of couples after 1 year find that they are unable to conceive and then usually seek physician help for achieving a pregnancy.
The reasons for infertility range from the increasing age of moms when they choose to have babies. Endometriosis can scar the fallopian tubes permanently, but also the increasing problems with sexually transmitted diseases.
Sexually transmitted diseases are literally epidemic. It's an incredible increase in chlamydia and gonorrhea and herpes and human papillomavirus, cervical cancer, all of these things, many of which lead to scarring of the tubes and subsequent infertility. Now, there are other things that cause it as well, and they probably are related to stress and what it does to the hormones that are involved in reproduction.
But is infertility on the rise? What contribution has society made to this problem, and what is it about the way we lead our lives that has changed?
Infertility is common in the United States. This affects literally millions of people. From the numbers, we know it's probably going to continue to increase simply because there's a 5-fold increase between 1975 and 2006 of moms having their first babies when they're older than 30 years of age.
In the 1970s, we found that women aged 35, they comprise only 5% of the population that were pregnant. We're finding now that women are delaying marriage, delaying childbearing, many are seeking professional lives, and so that population of women that are over age 35 now comprise about 24%.
Women who are out of their 20s, just because of the mere fact that they're older, the eggs have been around longer, we know have increased risks. There's increased risk of chromosomal issues, there's increased risk of the pregnancy not taking, and there isn't anything in medical science that changes that. That's a truth. If you're not pregnant in your 20s and you're over 35, there's different risks involved, and just those alone can put you and the babies at higher risk of problems.
If you go back 30 or 40 years to when a lot of this got started, it would be true to say that we really didn't know what caused infertility. So that was one problem. The second problem was the insurance industry has, for many, many years, up until the present time even, discriminated against those women who have infertility problems because they've always seen it as kind of a personal issue as opposed to a real medical issue. These women actually have real underlying medical issues quite aside from their fertility issues. And I think the third thing is that when in vitro fertilization came about, it was like these doctors wanted to be on the cutting edge of everything, you know, and this was the newest technology, and that really meant a lot to them.
We're fascinated with high tech, fascinated with cars, with speed, fascinated with fast computers, and we have this mistaken idea that if we can solve something technologically, that it's better. And every technological advance that we have has a price to pay. With artificial reproductive therapy now, it's sexy and neat to go in and have the embryos fertilized and placed inside the uterus. But there's a price to pay. And I don't think that many of our patients and families that use IVF, artificial reproductive therapy, are aware of the price.
The technology we're using, given that the success rates are, 35, 25%, how good is that? You know, in today's day and age, all our children who ride in cars have car seats. We don't take those risks because there could potentially be a bad outcome. And yet there is a way bigger chance that if you go through IVF, at least one embryo, probably a whole lot more, will be dead. There's a much bigger chance that the baby is going to be born prematurely. There is a bigger chance that there could be lifelong permanent problems. And imposing our ethics on our technology doesn't limit the technology. We're asking it to be better. We need to ask that our technology absolutely be wed again with our ethics, and the ethics being better outcome and certainly less chance of human death, babies, and sometimes complications for moms too. This has got to be addressed. That's not stifling technology. That's asking it to be better and step up.
Before examining the different methods of reproductive technology, it's important to understand that most procedures can be classified in one of two ways.
There's two big groups of assisted reproduction. There's the methods that deal with keeping the conjugal act intact, and reproduction still occurs between a man and woman, as opposed to the in vitro, there's a baby formed in a dish and then replaced. And that's kind of the two big branches of assisted reproduction. It's either in a dish or not. Sometimes the mom isn't producing enough eggs, and you get into a place where there's a lot of medicines where they use what they call hyperstim.
What they use are mostly the injectable drugs that stimulate the ovary to develop multiple follicles. And these contain hormones like follicle-stimulating hormone, which is a naturally occurring hormone, but its role is to stimulate the ovary.
If there's more eggs to choose from, is there a bigger chance that you can be pregnant? The problem with this is you have a much higher rate of multiple pregnancies. And anytime that there's multiples, there's higher risks.
If you look at singleton pregnancies, most singleton pregnancies will deliver around 38, 39 weeks. Twins as a whole deliver around 35 weeks, and triplets deliver at 32 weeks. And quads will deliver an average of 10 weeks early at 30 weeks. So this presents our neonatologists with some interesting issues and problems.
Depending on the type of multiple they are, whether it's the babies are together in one sac or they're fraternal twins, they're in more than one sac has more problems than when it's divided up into more. They get all kinds of blood vessel connections, and those kids are much higher risk of both survival and long-term consequences.
The septuplets that were born were the result of this type of technology. Well, those babies were all born very prematurely, and it's a very tough road for that group of babies in their being born. It's a very tough pregnancy on the mother, because human mothers are not designed to carry 7 or 8 fetuses.
Gary and Tanya Roberts were given Clomid, a drug often used to treat female infertility, and they were able to conceive, but nothing could have prepared them for the consequences they faced as a result.
We tried to have kids, and it didn't, pan out the conventional way. Just we thought maybe something was wrong with ourselves, so we went to the doctors. The doctor had suggested Clomid. It never come up, well, hey, you could have twins or you could have more, and that you would lose anyone. He had said, about complications of possible, well, they might be a little underweight, they might come a little bit early, but to be told about the long term of what you could actually face, nothing I don't think was ever really said.
I was 24 weeks pregnant, the membrane had ruptured, and they put us in an emergency type room, I don't know what they call it, and they checked the clothing to see whether or not it was an actual water break. After the 24 hours, that's when the kids decided they wanted to make their appearance.
The first time I kind of left her side was the next day on June 30th. I went downstairs to call her parents to see where they were at, and I wasn't gone another 15-20 minutes. And my phone's ringing because they're taking her to the emergency room to do emergency C-section. They made me wait at first outside of the room, just I guess to where they get to a certain point, and then they let me in there. She's laying there, the doctors are around her, and on my right side I could see that there was a nurse and a doctor working with one of the babies. And on my left side there was one of the babies right there inside the door, and there was a nurse and a doctor working there. And then on the other wall, to the left of the second baby, there was a nurse and a doctor working on another baby. They were all in the incubators, and they referred to the babies as A, B, and C. Then he kind of told me, well, baby B over here is doing fine. We've got him taken to breathing on his own, and we're kind of getting him cleaned up, and baby A is right behind him, you know, he's doing fine. Our problem is with C. And the doctor kind of proceeded to tell me that, you know, they were working their hardest, they were doing everything he could. They could not get baby C to be able to start breathing on his own or to do anything without their assistance. For someone to walk up to you and tell you there's nothing they can do, I wanted him to give me some more time, give me at least 15 more minutes or something. So the doctor agreed, you know, okay, he would do what he could and give me that time. And I just went to the other two, to baby A and baby B, you know, and just kind of said a few words for him and stuff, and let him know that I love him. And I went over and I sat with Tanya, because she don't remember a lot of it. I gotta be the one to remember for both of us.
If a couple has tried unsuccessfully to conceive through the use of drugs, they will often resort to more drastic measures, such as in vitro fertilization.
There are a number of methods where the big picture is eggs are removed and sperm is introduced to the egg outside of mom, and you have a fertilized egg, an embryo, that occurs through a medical technician. The fertilization process happens outside of mom. After that, the egg is reintroduced, or eggs are then reintroduced into mom.
The claims made by IVF doctors as to the effectiveness of this method are not accurately represented due to the standards by which success is measured.
Well, the IVF clinics have developed their own measure of success, which no other infertility procedure uses. They look at the success rate per cycle treated. In the year 2007, there were 138,000 cycles of in vitro fertilization that were started in the United States. That means they've collected an ovum, they've collected the sperm, they've united them, and they've implanted them or transferred them into the uterus. And of course, some women go for more than one cycle, although it's so expensive that the average number of cycles is less than 2 per woman. But it comes down to about 74,000 women have received services from the IVF clinics. They try to calculate the percentage of women who get pregnant in a given cycle, and it usually comes out about 25 or 30%.
By the national summary standards, we define currently success in infertility as a pregnancy. Only 35% of IVF cycles result in a pregnancy. Only 25% of those actually make it to birth. Live birth is defined as simply being alive at 22 weeks. At 22 weeks, the baby is only questionably viable. There are babies at 22 weeks, I can't get tubes in. There's babies at 23 weeks and 24 weeks that are too small for us to rescue. It's not a fair assessment, and it's not even a fair number then of how successful this entire industry actually is.
And the risks associated with in vitro fertilization often outweigh those of fertility drugs because the procedure can, at times, be practiced irresponsibly.
There are about 6 embryos lost for every one that survives. There's data to show that if you put 2 or 3 or 4 embryos in, the chances of one surviving is much better than if you just put one in.
Their success rate isn't that good. It's under half. So they'll introduce more eggs in the hope of getting one.
For a long time, the number of embryos that were inserted at one IVF setting was in the 3 to 4 range. Well, they had a very, very high rate of multiple pregnancies when they did that. So the private organizations involved in all this encourage their doctors to just insert 2 embryos instead of 3 or 4. Now, some of the groups have done that, but they know that when they insert a fewer number of embryos, that their overall success rate goes down.
We also have families, remember, that say, this is my life saving, we'll do anything, just implant as many, as you got. If we had 6 that were harvested and you think those are viable, let's go for it.
If they've tried and done this and put their whole life into it, there's a lot of emotional baggage that goes with this, and it's very tough.
Some clinics in implanting embryos will give the patient a license and in the name of autonomy and implant as many as the couple wants. And we know from recent headlines that this can give rise to some difficulties.
For those embryos that land in the uterus and stay there and continue to grow and develop, they have a miscarriage risk in the first 12 weeks of pregnancy, which is higher than normal. And they have a much higher prematurity rate, as I had indicated earlier. And when they're born prematurely, they have the risks of prematurity, most of which are things related to cerebral palsy or cognitive or developmental disorders that they might develop as they grow into childhood and adulthood.
There is a 30-fold risk of a multiple with in vitro. I believe double the risk of being small for gestational age, and over that for once you're in multiples, being born prematurely. Even for singletons, there's increased risk for prematurity and being small for age and having all of the complications that simply being premature is, and more complications if you compare them with just a single naturally conceived infant. They don't do as well. The highest risk group are the kids that are born around the edge of viability. Viability is around 22, 23 weeks. Term is 40. So these kids are literally half-baked. The lungs haven't really formed the little air sac at the very end of them called the alveolus, and that's where air is exchanged. We can give a medicine called surfactant, which as the lung grows, it secretes normally. But if the alveolus itself hasn't formed, I can't make it be there. So that's problem number one, is the baby far enough along where they can even breathe in oxygen and get rid of carbon dioxide? So that really does, in many ways, often define whether the baby even has a small chance. That's lungs, is the first big organ system I worry about. The second one is infection. Basically, babies are born without an immune system. They're pretty helpless, even to the point where normal bacteria that's on all of our skin in them can absolutely be fatal. And all of them, because they can't take in enough food to sustain life, need IV access. As soon as there's IV access, now you've got more entrance ways for bacteria to get in. If there's an infection, it can do terrible things to the lungs, which are struggling just to mature as it is, and there's this huge cascade of what can go wrong. The third big area I worry about is probably the one I am the least able to do anything about except worry, and it's probably of the three the most devastating, and that's a bleed in the brain. When in utero, this period of time is probably the period of the most rapid growth of the brain, so it's incredibly vascular. If those vessels break, they bleed into an area of the brain where they're making new cells. And if it bleeds out of that inner area, out of the ventricles itself, into the outside area, it destroys white matter. It just literally can destroy tissue, so you're left with holes in the brain. If it is a huge bleed, they're going to be at a starting place that I can't fix. In the worst case scenarios, what if the baby doesn't recognize you? Can never eat by itself, can never walk or talk. And it's one thing for an infant who is a couple pounds to be completely dependent on you. It's another thing when they're 4 and 5 years old or bigger, and they are still completely dependent. There are certainly more problems that can happen during the course of being in the NICU. One of the big ones that we live in fear of because it can be so catastrophic is something called necrotizing enterocolitis, abbreviated as NEC. This basically is a catastrophe that happens to the bowel. It's a spectrum of disease, so it can just, first of all, hit just a little segment of the bowel and only the very inner cell layers, or it can be totalis, the entire bowel, and if it goes all the way through the bowel wall, it's a perforation, and you have basically stool out in the open peritoneum. You can't survive without your bowel. Sometimes, if there's just a small area of necrosis, of dead tissue, that can be removed surgically. If it's the whole thing, the baby can't make it.
A close examination of the risks associated with in vitro fertilization and the use of fertility drugs may convince many not to pursue either course. It may be surprising to learn that not only do other methods treat the woman's infertility, but also her overall reproductive health.
If you could reach them ahead of time and explain to them what the chances of getting pregnant are by looking for the underlying causes and treating them, a large percentage of these women would opt for finding out what the diseases are that are causing their problem to begin with. NAPRO technology is the conjunction of the three words natural procreative technology. And in the early 1990s, we had been at this work with the crate model system for about 15 years, and I had been having all my patients, reproductive age women, charting their cycles, whether they had recurrent cysts or premenstrual syndrome or abnormal bleeding or whatever it was, infertility, recurrent miscarriages. First thing we have them do is learn the crate model system. This is a standardized system, and by that I mean the language that the women use to describe their observations of the various discharges that they observe is a standardized language. So when they speak that language, the doctor knows that language, and they all speak the same language. That's really important because it's not subjective anymore. But for example, if you have an infertility problem, the things we look for, we call these biomarkers or biological markers that they're observing. Mucus cycles that are markedly reduced in amount, we call them limited mucus cycles. They may have some premenstrual bleeding before their period starts. They can have brown bleeding at the end of their period for 3 or 4 days. So we're tying all of these biomarkers together, and it gets us going in the right direction for whatever evaluation we're doing. And you have these charts, they're extremely helpful. I mean, they give us a feedback that you don't get any other way. A physician, a standard regular reproductive doctor, cannot get the information that we get from these charts. And we do really a thorough hormones profile of their cycle. And then usually the last thing we do is a diagnostic laparoscopy, which is a surgical procedure where we put in a scope and look at the uterus, tubes, and ovaries, and that's where we find the endometriosis and the scar tissue and whether there's any blockage in the tubes and things of that nature. So it's a pretty thorough evaluation. That's what we start with. And then when we get that done, and it takes 3 or 4 months to get through this usually, once we get through that, we have the information. We can then recommend the different types of treatment that would go with an abnormal ovulation or a poor mucus cycle or a poor progesterone level or an endometriosis, whatever it might be. We can treat her with the various hormones or whatever else we need to treat her with. And then the charting becomes important because that'll tell them when they're the most fertile in the cycle. So it becomes part of the treatment as well. And so now we're still training doctors, of course, we're training teachers, and we're training specialized obstetrician gynecologists. We have a 1-year fellowship program where we're training these young doctors to learn the surgical techniques that are involved. One of the things that with NAPRO technology that's probably a little bit different and something we'd like to change is that it still takes a while for people to get pregnant. It doesn't happen overnight. We'd like to, of course, speed up the process if we could, and we're working on that as we speak. But still, the end result is the pregnancies that they get, and if it does take a little longer, well, then we're going to have to live with that for the time being anyway. But our success rates are pretty good.
For couples who need help conceiving, there is hope. But the first step in conquering any infertility problem is a proper understanding of the causes behind it. If you are having trouble conceiving, talk Talk to your doctor about what can be done to diagnose the underlying problems contributing to your infertility. And if your reproductive specialist recommends in vitro fertilization or fertility drugs, pay careful consideration to the risks involved. With a bit of education and a bit of patience, it is possible to minimize the unnecessary risks.
If you go to an infertility specialist and one of the first things that he or she recommends is IVF, a question about a complete and thorough workup, and there's always the place to go for a second opinion.
One of the things that I've found is that if you sit down and explain these things to these patients, believe it or not, they're actually more interested in knowing what's wrong with them. They know, they have an inner sense that they know there's something wrong, but nobody will pay attention to it.
If they had told me before that I had to make a decision like that after I said yes to Clomid, I would have said no. We'll just deal with the time, and if it happens, it happens.
Taking care of babies is my joy, it is my privilege. I get to see the miracles. I also get to help families through the unthinkable, which is when a baby arrives damaged or becomes damaged during the process of being born prematurely. When it happens to families who have gone through so much just to try to become pregnant, for these people, my heart absolutely turns over. But worse to me is for them not to know ahead of time what they're getting into when they even enter this process. My goal is to talk with people before that happens, when you can still hear the realities, when you can still hear all the potential things that could happen. Like I say, there are so many people who have been helped by assisted reproduction, and that's amazing. But there's so many who have been devastated, who didn't have a clue what they were getting into, who might have made a different choice. People need all of the information to be able to make the choice that's right for them. That's what this is about.